So, in the series of Learn Simply Academy, this is the topic called prolapse and recurrent prolapse surgery. Then we are supposed to do the assessment and the corrective surgeries. Now, the roadmap, what we will learn, assessing the ward after prolapse or hysterectomy. Then we will also learn the choosing between the vaginal and abdominal approaches. Then we will learn about the core apical suspension techniques and why prolapse recurs and how to plan the revision surgery. A common cause of reoperation is it's almost 30% lifetime risk of second prolapse surgery after the first, and 1 upon 9 women undergo prolapse or incontinence surgery by the age of 80. Vaginal ward support level 1, cardiac and uterosacral ligaments suspend the apex. Loss of these support allows the wall to descend, and level 1 failure often drags level 2 and level 3 support with it. Now, causes of wall prolapse after hysterectomy are apical support not adequately addressed at the time of hysterectomy, underlying connective tissue weakness, and chronic increased intra-abdominal pressures can lead to the wall prolapse. Now, predictors of recurrence is advanced prolapse stage in initial surgery, young age at the time of first repair, and chronic straining that persists after the surgery. Now, clinical assessment of doing the wall prolapse, full POC-Q examination at rest and with Valsalva, identify the vaginal scar and locate the apex precisely, and assess all the compartments. The recurrence is rarely isolated. Staging wall prolapse point C. Point C marks the vaginal cuff or the cervix position, measured the relative to the hymen, same as the other points, and correlate stage with the functional symptom, not just numbers. Diagnosis: assessing the concurrent enterocoele, palpate the distinct bulge between the rectum and the vagina. Confirm on standing examination if unclear supine. That an unrecognized enterocoele is a common cause of recurrence. Then what planning we should do for this type of revision surgeries? There is a workup. Review the operative note from the original surgery, assess the occult stress incontinence, and optimize the comorbidities before the second surgery. Decision making is choosing the route vaginal or abdominal. Vaginal is a better route. It's a faster recovery, lower cost, and preferred for most patients. Abdominal or laparoscopic surgery, considering for young sexually active or recurrent cases, and sacropraxy offers durable apical support. Technique: sacrospinous ligament fixation, anchors the wall to the sacrospinous ligament, well suited for most primary and revision cases. Watch for pudendal vessels and nerve proximity. Uterosacral ligament suspension restores support along the natural axis of the vagina. Bilateral high suspension improves the durability. Identify the ureter before pressing the suture. Technique: 𝗩𝘂𝗥𝗚𝗏 fixation, usually alternative when sacrospinous axis is difficult. Suture placed into the 𝗩𝘂𝗥𝗚𝗏 fascia bilaterally, slightly less anatomic but technically very simple. Then 𝗥𝗲𝗏𝗏𝗪𝗀 when to consider, high long-term success rate for apical support, best for young patients for the repeat failures, and requires abdominal or laparoscopic access and a mesh. Then managing the concurrent enterocoele repair, excise the obliterated enterocoele sac fully, close the defect with same setting at the apical repair, and leaving it unrest is a common cause of failure. Obliterative surgery or a recurrent prolapse, colpoclysis, for a frail elderly patients not desiring coitus, very low morbidity, short operative time, confirm the document, informed consent clearly, and root cause analysis we should do via prolapse reflux, technical factors, inadequate apical suspension at the original surgery, suture failure or pull through of the ligament, and unrecognized compartment left unrepaired. Again, why prolapse recurs? Patients' factor are persistent connective tissue weakness, ongoing chronic straining like calf, constipation, heavy lifting, and advancing age and a progressive tissue changes. evaluating and field repair, determine exactly which compartment has recurred, distinguish true recurrence from misdiagnosis, examine or for mesh or suture-related complications. Then key principles for planning a revision surgery are: address every defective compartment in one sitting. Choose a technique different from what already failed. Set realistic expectations with the patient. Now, complications with the managing mesh complication in revision cases. Exposure, pain, dyspareunia are a classical triad. Partial excision often suffices. Full removal of several cases. Refer complex meshes case in an experienced center. Now, with these patients, we need most of the time the counseling the patients on the recurrent risk is very important. No repair eliminates recurrence risk entirely. So we should discuss the modifiable factors like weight, constipation, and lifting, and set up a follow plan to catch a recurrence early. So with all this, the clinical judgment, pearls and pitfalls, the pearls are always examine every compartment, not just presenting one. Then bilateral high uterus suspension improves the durability. Match the technique to the patient, not the surgeon's habit. What is needed is more important. But there are pitfalls. Leaving an enterocyl unundressed during apical repair is bad. Repeating the same failed technique on revision and skipping occult incontinence testing before the revision. So the key takeaways are summary and closing. Recurrence often reflects an unaddressed compartment. Match the suspension technique to the patient's anatomy. 𝗥𝗲𝗋𝗄𝗧𝗏 offers the most durable apical support. Address enterocyl and occult incontinence proactively and set expectations. No repair fully eliminates recurrence. Thank you so much.